Good morning, everybody. So let's talk HIV today. And first of all, I would like to thank the President and the Council of the Kurunegala Medical Association for inviting me for this lecture. So during the next 1 hour or so, I will be talking about, or I'll take you through a case history and the epidemiology of HIV, indicator conditions for HIV testing, stigma and discrimination associated with people living with HIV, and pre and post exposure prophylaxis. And also, I will be talking a little bit about recent advances in HIV treatment, especially during 2025. So I think it is really important for you all to get familiarized with the signs or symptoms or the case scenarios. Undiagnosed people living with HIV present to your clinical setup, maybe to the medical ward, respiratory wards, even to surgical and other specialties. There are a lot of undiagnosed people living with HIV presenting to us. So during your day-to-day life, to think about HIV, it's better to have a have an understanding of this case scenario. So this patient was referred to us from our colleagues from base hospital in the Kurunegala district. He's a 49-year-old married male, and he presented to a medical ward with gradual weight loss for 2 years, which became apparent in the last 4 months. And he was also having cough for 4 months with minimal sputum production, no hemoptysis or diurnal variation. And he was also complaining of intermittent low-grade fever with night sweats for the last 4 months. He has developed breathlessness, especially on exertion for the last 6 weeks. And he was investigated for tuberculosis twice before his admission to the ward. And he had, apart from his elevated ESR, rest of the investigations were found to be negative for tuberculosis. And he was started on empirical antibiotic treatment, and inhaled bronchodilators also prescribed, but with a poor response. When he was admitted to the ward, he was emaciated, he was pale, and he was having oral candidiasis, but no lymphadenopathy. And on the examination of the respiratory system, he was having very occasional creps bilaterally, and saturation was 97% on air. So the initial investigations were conducted, and the full blood count showed mild neutrophil leukocytosis. HB was 7.4 with platelets 130,000. Yes, ESR was 64 millimeters first hour, and liver functions and the renal functions were within the normal range. TB screening was conducted while in the ward, and all the testing for tuberculosis was negative, and sputum TB culture also came as negative later on. And the chest X-ray was showing features in favor of atypical pneumonia, and standard treatment for atypical pneumonia was started, but the patient's response was poor. Fortunately, the clinicians suspected there's something going on, and they referred the patient to the STD clinic for HIV screening because of the poor response as well as the hematological abnormalities. And he was found to be retroviral positive, and his CD4 count was very low. It was 42 cells per microliter, and his LDH was high. Then, because of those findings, his respiratory symptoms were recategorized as new sister sclerosis pneumonia, and significant exercise-induced oxygen desaturation was also noted, and anemia was reported as anemia of chronic disease. So at the STD clinic, we go through, we get a lot of details regarding his social as well as the sexual history, and he was a catering service operator. He's serving food mostly to local tourists, and he has 2 grown-up children. And he's separated from his partner, his wife, for 10 years and lives alone. And when we explored more into his sexual behaviors, he said that he was having male-to-male sex relationships for the last 15 years or so. So that is really important because these male-to-male sex relationships are really important, and we consider MSM as key populations who are driving the HIV epidemic in Sri Lanka. So let's move on to, so this patient we managed with the VP and later on now he's doing well on antiretroviral therapy. So now I'll move on to the epidemiology of HIV. So you can appreciate how the HIV infection has progressed and the trends of HIV by sex from 1995 to 2025. During the year 2025, there have been 873 new cases of HIV diagnosed, and out of that, 749 are males and 124 were females. And from 1995 to 2025, we see a stable prevalence or incidence of HIV among females in Sri Lanka. But in 2025, we are seeing a slight increase. Usually, the HIV new HIV diagnosis among women remains below 100 per year during the last few decades. But in 2025, we are seeing a slight increase at 124 females being diagnosed with HIV. So what is the risk of these data? So from the 749 males who were diagnosed with HIV in 2025, 70% of them had male-to-male sex. So these adult men who are practicing these male-to-male sex behaviors are the major contributors to increasing HIV cases in Sri Lanka. And the other important thing is in Sri Lanka, MSM behavior is criminalized, and due to a lot of social pressure and cultural pressure, most of these MSM, they have heterosexual exposures as well because there's a lot of pressure to get married. So actually speaking, in Sri Lanka, majority of the MSM or gay people are bisexuals. So there's this indirect risk of men acquiring HIV through male-to-male sex and then transmitting it to their female partners. So what is the consequence of females getting more and more females getting infected with HIV for our country? It is mother-to-child transmission of HIV can be increased if we are getting more and more females. So HIV can be transmitted from mother to child while the baby is in the uterus during delivery as well as while breastfeeding. So when we quantify the risk of mother-to-child transmission of HIV in utero in the early weeks of POA, it is very low at 1%, and from 14 to 36 weeks, it's 4%. From 36 weeks to labor, it is slightly increased up to 12%, and during the short period of labor, it is at the highest with 8% of risk transmitting it to the baby. And there's an additional risk of HIV transmission via breastfeeding, 7% if the mother breastfeeds only up to 6 months, and if the mother breastfeeds up to 2 years, the risk will be increased by 3%. And overall, without breastfeeding, the risk of mother-child transmission of HIV is 25%. Overall, with breastfeeding till 6 months is 30%, and overall with breastfeeding till 2 years is 35%. So in Sri Lanka, all pregnant women should undergo HIV testing, ideally during the first trimester, and those who are at risk of acquiring the infection in the later stages of the pregnancy, they are being offered another testing at the third trimester. And Sri Lanka is a country which has been validated as a country eliminated HIV and congenital syphilis since 2019, and we have included hepatitis B into this universal screening, which is conducted via MOH ANC clinics. And since June 2026, we are conducting tests for HIV, syphilis, as well as hepatitis B for antenatal mothers universally. Then, this is the summary of HIV epidemic by the end 2025. According to the AIDS epidemic model, which considers the population of a country as well as the reported HIV cases in the past few years, it is estimated that around 8,678 people should be living with HIV at the end of 2025. However, only 66%, 5,744 people know their status at the end of 2025. So there's a gap of around 3,000 people who are living with HIV without being diagnosed. So it's a great risk for the public if we don't diagnose them properly and start on antiretroviral therapy. Out of that known patient, I mean, who have been diagnosed with HIV, 4,582 are in clinical services and are on antiretroviral therapy. Then we look at the trends of CD4 counts at the time of HIV diagnosis from 2021 to 2025. And you can observe that almost 1/4 of the new HIV diagnoses were diagnosed when their CD4 count is less than 200. And in 2025, there's a slight increase of patients who have been diagnosed in the 8th stage of the infection. And this is the real problem, because HIV has a latency period of 10 years from HIV to from HIV infection to develop symptoms and to become AIDS patients. It takes some time. Sometimes it takes around 10 years. So during that period, people can transmit the infection either by sex or from mother to child. So there's a huge risk if we let these people uh, uh, without diagnosing and without putting them on ART. And therefore, we need to explore the reasons behind this late diagnosis of HIV in Sri Lanka. So what are the reasons? These are the common reasons we have found out that which differs clinicians from offering HIV testing for their patients. First one is they don't know or they are not aware of the HIV indicator conditions, on which I will be elaborate more during the next few minutes. And also thinking HIV is rare in Sri Lanka is a common thing, because most of the time if there are patients with pyrexia of unknown origin being investigated in the wards, they undergo a lot of expensive investigations to rule out or diagnose many exotic infections. But nobody thinks about HIV. So HIV is not rare in Sri Lanka. We have to always think about HIV as one of the priority differential diagnoses. And the other one is HIV needs, the clinicians think HIV needs detailed pre-test counseling. Yes, it needed detailed pre-test counseling prior to introduction of antiretroviral therapy. That is because if someone was diagnosed and labeled as HIV, they'll eventually die due to AIDS, because there were no available antiretroviral therapy to control their infection. So in the initial stages, doing an HIV test and telling the patient that you are HIV positive is like giving the death sentence. So those days, it was really important for us to do detailed pre-test counseling before HIV testing, but not anymore. Now we only have to give pre-test information and do the test. So what you have to say to the patient is, due to your condition, it is better to get this test done, and we do it under strict confidentiality, so we'll do it and manage accordingly. So that is only what is needed. And even in last month also, some of the doctors called our clinic and asked how to do pre-test counseling for HIV. So you don't need to do a lot of detailed counseling for HIV testing. Just give them the pre-test information and do the test. And the other one important thing is people consider individual patients are at low risk for HIV infection, considering their social, educational, or other financial backgrounds. But that is not so. We are seeing people who are having postgraduate qualifications with HIV, who are multimillionaires with HIV, and also homeless people who don't have even a place to keep their drugs with HIV. So it is immaterial. Don't think that individual patients are low risk of HIV by thinking about their social, financial, or educational background. Okay. And the other thing is, this is important in the ward setup and the GP setup, because doctors are like reluctant to offer HIV testing because they fear the response of the patient. They think what the patient might think of me. The doctor thinks I'm a very bad patient with bad behavior. So you all are reluctant to offer HIV testing. But you don't have to be reluctant. Just offer this routine test so that we can avoid diagnosing people at very late stage of HIV. So it is very detrimental for the patient themselves and also to the public health budget, because it's very costly to manage patients who need a lot of medications, who need ICU care, and who need a lot of expensive investigation. Right. So now I will talk about the HIV indicator conditions and indicator condition driven HIV testing. HIV indicator conditions are diseases or symptoms of infections associated with HIV infections. There are two types. One is conditions that are AIDS defining. And the other one is non-AIDS defining. These conditions are associated with undiagnosed HIV prevalence of more than 0.1%. So we'll discuss system-wise. So if when we consider the respiratory system, if the patient is having tuberculosis with retroviral positivity, the patient is in AIDS stage, and we have a very good collaboration with the chest clinic and the chest physicians. All the people who are HIV positive are sent for TB screening, and all the people who are TB positive are sent for HIV screening to the STD clinic. So TB, we are doing very good collaborative work. But the other conditions where people are coming with recurrent respiratory tract infections, young people who are getting bacterial pneumonias, all those things are called indicator conditions. And if we can do HIV testing for those people, also we can diagnose a lot more new cases of HIV. And in the central nervous system, cerebral toxoplasma, cryptococcal meningitis, progressive multifocal leukoencephalopathy, PCNSL, and aseptic meningitis, cerebral abscess, transverse myelitis, dementia, and space-occupying lesions of unknown cause, they all are HIV indicator conditions. The skin is really important because majority of the patients who presents to our clinics at very late stage of HIV, they have a file of investigations and medical records, and majority have been to dermat units, dermatological clinics with these skin problems. And those are Kaposi sarcoma, which is rare in Sri Lanka, and the common conditions in the skin, dermatological aspect is severe seborrheic dermatitis, severe psoriasis, multidermatomal or recurrent herpes zoster. And the gastrointestinal system, esophageal candidiasis, oral candidiasis, chronic diarrhea of unknown cause, oral hairy leukoplakia, weight loss of unknown cause, and also hepatitis B and C infections are considered as HIV indicator conditions for testing. And oncological point of view, non-Hodgkin's lymphoma, cervical cancer, anal cancers, lung cancers, head and neck cancers, intraepithelial neoplasias, all those are HIV indicator conditions. And in the eye setup, CME retinitis is an AIDS defining condition, but we have to also consider HIV testing in patients who are having infective retinal diseases, including herpes virus or any unexplained retinopathy. ENT, chronic parotitis, is an indicator condition, and hematological point of view, we need to do HIV testing in unexplained anemia, thrombocytopenia, and all the patients who have been investigated for pyrexia of unknown origin or lymphadenopathy of unknown cause, or any patient who are having any STI should undergo HIV testing, and those are called HIV indicator conditions. So if you know these, and we can, I think, by ordering HIV testing, we can find many more hidden people living with HIV. So these are few common HIV indicator conditions. This is recurrent aphthous ulcers, oral candidiasis, esophageal candidiasis. This is oral hairy leukoplakia and fungal nail infections and severe seborrheic dermatitis. So HIV indicator condition driven testing is clinically effective but still rarely implemented. The prevalence of previously undiagnosed HIV has been demonstrated to be more than 0.1% in a wide variety of indicator conditions. You know, if you look at this table, I don't know whether it is cluttered and all, but they have tested 126 patients with hepatitis B for HIV, and 13 were positive for HIV. So the prevalence was 1.2. And they have tested 299 people with severe seborrheic dermatitis for HIV, and 6 were positive. The prevalence was 2%. So routine testing for HIV is cost effective at a prevalence level of about 0.1%. So all these indicator conditions, if we test HIV initially, it is very cost effective. And the other thing is this will also remove the need of assessment, risk assessment. If the patients are presenting to you all with these kind of indicator conditions, you can do the HIV testing. You don't need to go for a detailed sexual history or anything, just offer HIV testing. And the other thing is it will normalize the test. Now in the ANC setup, because now we do universal screening of all antenatal mothers, the stigma is not there. So we can normalize HIV testing if you offer more and more HIV testing for people who are presenting to you all with HIV indicator conditions. So I'm talking a lot about HIV testing. So what are the tests we have? First, we do the standard screening test and then go for the confirmation. And we have fourth generation lab-based test or point of care test using blood, that is rapid HIV testing and the ELISA. And also we have this third generation self-test, which uses oral fluid. So that only detects the antibodies against HIV. It is not that sensitive as these fourth generation tests, but we keep it for people who are reluctant to come to the STD clinic or people who belong to the key population. So people, our volunteers can go and do the self-test for them. And people themselves who think they are at risk of HIV can get the test done by themselves. And after one of these HIV screening tests become positive, we send the patient's blood sample to the National Reference Laboratory for Western blot, which is the gold standard for HIV confirmation. But it will take some time because all the samples from the district STD clinics as well as from the blood bank and private hospitals, they all end up at the National Reference Laboratory. So there will be a lag period of getting confirmed reports of these patients. Therefore, we do triple algorithm test for HIV confirmation at the district clinic so that we can plan the next steps of our management without delay for these patients. So next I'll talk a little bit about how we are planning to start antiretroviral therapy. Now the recommendation is rapid initiation of ART with 3 active drugs, and rapid initiation means we have to start antiretroviral therapy within 2 weeks of the diagnosis of the patient. But in some instances, like for pregnant women, we do initiate ART on the same day. They are diagnosed in the morning and by the evening we have started antiretroviral therapy. That is because it's really crucial to prevent mother-to-child transmission. And usually what we are now using is the triple drug combination of tenofovir, ampicillin, and dolutegravir. These drugs are really potent and they can make the people's viral load undetectable by 1 month of starting treatment. And if there are severe opportunistic infections like TB or any CNS infections, we have to wait for at least 2 weeks before initiating antiretroviral therapy to prevent immune reconstitution inflammatory syndrome. Also, we have to tailor-made some of these regimes if the patient has other comorbidities, and we have to check drug interaction because there can be a lot of drug-drug interactions if the patient is on a lot of drugs for opportunistic infections. Now, I was talking about early or rapid initiation of ART. Sri Lanka first got antiretroviral therapy for our patients in 2002. And those days we were giving antiretroviral therapy for pregnant women during their pregnancy only. After they delivered the baby, we stopped antiretroviral therapy. By 2004, we have had another stock or another provision of antiretroviral therapy. Then we started giving them when their CD4 counts are below 200. So we were waiting till the patient's immunity lowers up to stage 8 stage. But in 2010 to 2015, we were waiting till their CD4 counts dropped to 350 and then initiated ART. But in 2015, this study was conducted and it was called the Insight Start study, and it showed that when ART starts immediately, there will be significantly less serious AIDS-related events and serious non-AIDS-related events and deaths from any cause when we compare to the delayed ART initiation now. Therefore, in 2016 onwards, Sri Lanka has adopted the concept of test and treat. Once people are tested and are positive, we start antiretroviral therapy rapidly. So what are the benefits of initiation of ART early? That is twofold. One is the individual benefits. It is now the main pathophysiology of HIV is ongoing immune activation and damage to the immune system. So we are measuring by CD4 counts, but it is not only the lowering of CD4 counts, but there's a lot of other damage being done to end organs. Okay, so the prolonged immune deficiency and viremia will lead to opportunistic infections, malignancies, and non-communicable diseases like cardiovascular disease, strokes, and kidney diseases. So therefore, if we start ART early for these patients, we can preserve their immune level as well as the other systems and prevent all these non-communicable diseases for their future. And the other important benefit is the public health benefit. If we start treatment early, as I told you earlier, their viral load will be undetectable by 1 month of starting antiretroviral therapy. And then we can prevent zero onward transmission through sex, from blood products, or from mother to child transmission. Therefore, U equals U means undetectable equals untransmissible. So initiating of ART early is really important if you are to end AIDS by 2030. So now, because of this potent antiretroviral therapy, HIV has become a chronic disease, which only requires single pill once daily, and therefore we expect there has to be no stigma or discrimination associated with HIV, but it's not so. We see a lot of people living with HIV facing a lot of stigma and discrimination in the society, healthcare settings. And the people living with HIV organizations conduct this study 2 yearly. They are assessing the stigma index, and they have reported that they are being stigmatized and discriminated mainly from their close relatives or family members or their spouses. And the second in the list is healthcare workers. So at the healthcare setting, they are being stigmatized and discriminated. But when I entered the program in 2009, it was severe stigma and discrimination was there, but now things have improved. Now we see less stigma and discrimination. Still, there have been few incidences reported during the last few years. So what are the reasons for stigma related to HIV and STD? First one is we fear that we can acquire HIV and STD by providing care for these patients, and lack of knowledge and myths on HIV STD transmission, and also the negative attitudes towards people affected by HIV and STD. But sometimes people have acquired HIV from mother to child transmission. These young children, they have acquired from their mothers. And some of the women or men, they have loved one person, they have married one person, they have had sex with one person, but they have acquired HIV. So we shouldn't have any negative attitudes towards people living with HIV without knowing their background. And the other thing is we see a significant proportion of key populations in the cohort of people living with HIV, like MSM, men having sex with men, female sex workers, beach boys, and people who inject drugs. So there's double stigma because all these key populations are already marginalized in the society. So now they are having HIV. So they have double stigma, and because of that also there's increased stigma for HIV, STD in the healthcare setting and in the society as well. So what will happen if we continue to have this stigma and discrimination towards these people? So if a person is having a fear or they have actually experienced stigma and discrimination, This will reduce an individual's willingness to seek HIV testing or STD checkups. And they won't disclose his or her HIV STD status to others, to the healthcare workers or to their spouses. And they will not come forward and practice prevention. And they won't ask or give care and support. And they won't start treatment, and after some time they won't come to follow-ups. They won't adhere to treatment. So it is detrimental if we consider, if you start antiretroviral, they have to adhere to it properly to have undetectable viral loads and to prevent onward transmission. So all these things will badly affect our goal of ending AIDS by 2030 and prevention of HIV in the society. So in the clinical setup, what can we do to reduce stigma? So we have to give correct knowledge on HIV STD transmission modes, and always we have to practice standard and universal precautions for prevention of occupational injuries. And we have to always follow the protocol for post-exposure prophylaxis following occupational exposures. We can do all those things, but the difficult and what is most needed is to change the attitudes of healthcare workers. So it is really difficult, but with time, I hope that we can change the attitudes of healthcare workers towards people living with HIV. So I will be talking a little bit about other important aspects of HIV prevention. The first one is the behavioral interventions, including condom promotion. We have been advocating and educating patients or people to use condoms, to have to be in a monogamous relationship, to delay sex till marriage. All those things we have been telling for the last 3 decades. But from looking at the graphs, we can see the trend is rising. So there are very important biomedical interventions which have been practiced in other countries of the world and which have shown to be very effective. Those are the pre-exposure prophylaxis and the post-exposure prophylaxis for HIV. I'll talk a little bit about pre-exposure prophylaxis next. So this is pre-exposure prophylaxis for HIV. This is indicated for individuals with increased risk of HIV acquisition, such as men who are having sex with men, female sex workers, or people who inject drugs. And at the moment in Sri Lanka, only oral PrEP is available. So we use a fixed dose combination of tenofovir and emtricitabine in a single daily dose or on-demand usage. The event-driven or on-demand PrEP is recommended only for men having sex with men. I'll talk to you about these 2 regimes in a little bit. And so there have been, I'll be talking about this injectable ART, but the cabotegravir injection, which is given every 2 months, and lenacapavir injection, which is given twice a year, are recommended for clients with poor adherence to oral ART. So that is really important, because now if you ask someone to take a pill once daily, so they'll ultimately forget to take it and there will be poor adherence. But if the patients can come twice a year to the clinic and get the injection done, this is really effective. And I think this is the way out for us to prevent the further increase of HIV cases in Sri Lanka. But the thing is, it's really expensive. One injection costs around 9 lakhs, but when India starts to produce these generic products, I think we will be able to procure this lenacapavir injection, which is really effective. So we'll hope that we can get it in the near future. So this is the 2 regimes. I'll talk you through this. If there are some people who plan their sexual activities when they get their salaries or in the weekends, or when they're having chemsex parties, they have sex. So they have pre-planned sexual activities. For these males, we can give 2 tablets within the 2 to 24 hours prior to their planned sexual activity. And after the sexual activity, they have to take 2 tablets once a day as a tail period. So that is, we only give that for men having sex with men. And the other one is for people who are having risky sexual behaviors without any plan. So they are having regularly unprotected sexual exposure. So they have to take daily pills for 7 days to get their protection, or the lead-in period is 1 week. Then they have to continue daily one tablet daily till they cease their unprotected sexual activities. So that is what we are offering at the moment from our clinics. And it is really important to ask them to, although they are started on pre-exposure prophylaxis for HIV, to continue condom use to prevent acquiring other STDs like syphilis, gonorrhea, and HSV. Okay. So this is regarding post-exposure prophylaxis following sexual exposure for HIV. This is called PEPC, or non-occupational post-exposure prophylaxis. And at the moment, we are using this for people who have been gang raped, or who are having genital trauma after rape, or then for people who are having unprotected sexual exposures with high risk partners. For all those people, we are offering post-exposure prophylaxis following sexual exposure. So we are giving 3 ART drugs for 28 days, and the thing is, they have to take it as soon as possible after unprotected sexual exposures and within 72 hours. That is true for all our healthcare workers who are coming for occupational post-exposure prophylaxis. And the important thing is, for whether it is occupational or non-occupational, people have to start it as soon as possible and within the first 72 hours after exposure, and they have to take drugs if we start it for 28 days, and they have to come for follow-up at 6 weeks and 12 weeks. And in teaching hospital Kurunegala, if you face any percutaneous injury or mucosal splash or mucosal exposure, if the clinic is open, you can come and get the services. And if it is closed, you can get the HIV testing done from the night lab, and antiretroviral therapy is available at the A&E. It is open 24/7, so you can access that, and you can contact us so that we can prescribe the drugs and give instructions to you all. So never disregard any occupational exposure, because we have diagnosed people with HIV after healthcare workers were exposed to their blood or any percutaneous injuries. So why am I telling you that we have to start it as soon as possible within the 72 hours? So this is, I don't know whether you can see it properly. So once the HIV enters our body through mucosa or skin abrasions, the virus will be attached to the dendritic cells, or CD4 lymphocytes, which have the CD4 receptors for HIV binding. And this complex will be taken to the regional lymph nodes for destruction. But the thing is, CD4 lymphocytes are the target cells for HIV transmission. So what will happen is, once inside the regional lymph node, a lot of replication is going on of the HIV virus, and a lot of CD4 lymphocytes will be infected with HIV in the regional lymph node. And after maturation, and after 3 days of this process, all these HIV infected CD4 lymphocytes will be released into the circulation, and there will be widespread dissemination. It can go into the brain, the gall tissues, and the other lymph nodes, and all the other organs. So therefore, we have this window of opportunity of 72 hours or 3 days where we can start antiretroviral therapy and prevent you acquiring HIV after occupational exposure. So therefore, don't wait till 1 week, 2 weeks to come to get the services. Come as soon as possible and within 72 hours to get yourself assessed and start antiretroviral therapy if required. Okay, I am in the last segment of my lecture, so I will be talking a little bit about recent advances in HIV care treatment and prevention. So in the last few years, especially in 2025, we have seen a lot of promising interventions in the aspect of HIV care treatment and prevention. I will be talking about 3 of those. One is broadly neutralizing antibodies, gene editing technology, and IM injectable long-acting antiretroviral therapy. So the first one is this RIO study. It is a landmark trial which was conducted in the United Kingdom and Denmark, where they have selected men having sex with men who have acquired HIV, who were diagnosed with HIV, and they were started on antiretroviral therapy. And after they got their virological suppression status, they infused the study participants with broadly acting neutralizing antibodies or BNAbs. So what happened was, then they stopped antiretroviral therapy. So 39% of these participants were able to maintain their suppressive status without ART for 72 weeks, and some of them were able to have their virological suppression maintained for up to 2 years. That means with this early initiation of ART and immunotherapy, we can go for a sustained immunological suppression in the future. So it is really important when we think about HIV cure. And the next one is gene editing therapy. This gene editing therapy or gene editing technique has been used in many other areas in agriculture and all the other areas. Now it is coming into the healthcare sector. So what they do is they have guide RNA and Cas9 molecular scissor. So then the molecular scissor with the guidance of guide RNA will go and cut off the DNA regions of the HIV virus, which is embedded in our host DNA molecule. So 95% of transcriptional suppression has been achieved in these participants. So we have a very promising I think we can go for a sterilizing cure in the near future if we can develop this gene therapy against HIV. So I think it is possible for us to go for a sterilizing cure. Okay. Then the last one, I spoke about this earlier also. This is long-acting injectable PrEP. One is given 2 monthly, another one is given biannually. So if we can give them this long-acting injectable PrEP, their adherence will increase and we can curtail this rising HIV epidemic in the country as well as in the world. Okay, so these are my take-home messages. Please don't be misled by low epidemiological risk. Have a low threshold for testing if clinically indicated. Do not forget HIV indicator conditions. We are planning to produce a leaflet and to distribute it among the boards so that you can keep it on your table, and if there's anything you can offer HIV testing, and consider HIV testing in the initial battery of testing for pyrexia of unknown origin and help to reduce stigma and discrimination. So we are aiming to end AIDS by 2030 by achieving these 95, 95, 95 targets in the background of zero stigma and discrimination. So I think we can achieve that if we all get together, and as clinicians, if we test more and treat more, then we will be able to end AIDS by 2030. We only have 4 more years to go. Doubtful, but we'll try our best. Okay, so that is the end of my lecture.